Okay, good afternoon. We're going to get started shortly. Just waiting for one more viewer to come. We only have 2 signed up for today. Go ahead and pull up the PowerPoint presentation, or at least I think I'm going to. Okay, we still have only one person on, and let me try this again. Huh. There we go. And I'm going to share this screen with you. Again, we only have one person on so far, so I'm going to wait another minute or 2. I see I've got 3 attendees and 1 viewer. So if you're on and you can't see the screen for some reason, please let me know. I'm not sure why that would happen that way. So we might be all set though. All right. If you're on the call, if you see the chat box over to the right, would you please just let me know you're there, you're ready to go, and we'll get started. Now I see 2 attendees, so we might be having somebody might be having trouble getting in. Okay, Mary Kay, you're good to go. All right. And there was somebody else who was on, and then she disappeared. So I'm just going to give her another minute or 2. I don't know. Promise we'll be done on time, Mary Kay. I'm just waiting to see if she comes back in. Okay, I'm going to get started, and hopefully she won't miss too much here. So welcome, Mary Kay, again. And today we're going to talk about anxiety theory assessment, and we'll have a case to review again. Just in terms of, you know this already, 4 to 5 p.m. every Monday we'll be here doing this. At the end of today we'll have a course evaluation. Also, there is a worksheet that shows evidence of your participation in learning that you have to score at least 70% on. At the end, I will also send certificates within a few days of receiving those, the course evaluation and the worksheet. And of course, there is a referral incentive. So if somebody referred you and you list their name, if their name is listed 5 different times, and they get to come for free. So I'm hoping that this series only started about a month ago. So I'm hoping that over time it will grow. And I am open to doing training invites. Mary Kay, we talked about possibility of doing a webinar for your team there, which I certainly can do. All right. And I hate to do this, but I'm just going to go through this just because I'm waiting for this other person to come back in. My background was I went to Lemoyne College, which is in Syracuse, New York. I got my MSW at SUNY Albany, graduated in '93, and got my PhD in 2010. I got a SAMHSA dissertation grant, actually studying adolescent addiction treatments. And also, I am a Harvard Geriatric Social Work Scholar. The bulk of my early experience was with adolescents. I was with New York State Oasis for 6.5 years. I was also worked in the area of managed care, both full and part-time, and worked in the area of quality management, referral, and level of care review. I've been with the VA, working with veterans for 8.5 years. And I also teach part-time, 2 courses at a time at USC. And in the past, I taught at SUNY Albany. And of course, now doing this live online learning series. And unfortunately, the other person is not coming in. So the goals of today's webinar are to learn relevant theories pertaining to anxiety, to understand and apply the DSM-5 diagnostic criteria and prominent symptoms of anxiety, learn what clinical tools and techniques can be helpful to facilitate accurate assessment and diagnosis of anxiety disorders, and of course to successfully address your individual learning goal. Mary Kay. If you haven't already, write down in the chat box what you hope to gain from this webinar today, and you can also put it on your worksheet. So I'll give you a minute to do that. I know we're about a 10-second delay here. And while you're doing that, I'll give my disclaimers that although I'm an employee at both VA and the University of Southern California, this presentation is done independently of those positions. The views expressed in this presentation are those of this author and do not necessarily reflect the opinion, position, and policy of the VA, the U.S. government, or USC. I'm hoping your learning goal is going to pop up soon, Mary Kay. I'm kind of waiting for it a little bit here. I'm wondering if you're having technology problems too. All right, I'm going to move on, and hopefully this will happen. I like this pretty fairly powerful concept of anxiety. Okay, got it now. I have an 8-year-old patient with a recent serious mental issue. He's so, 80-year-old. Okay, he's so anxious and fearful. I'm not sure how to handle this. 80-year-old patient, recent serious health issues, so anxious and fearful. Okay. Okay, we can talk about that today. So obviously this is a bit of a metaphor for anxiety, but to kind of really talk about this metaphor, not to be too graphic, but you have the situation where this mouse is so scared that it's going to the bathroom, but and anxiety is about a fear of what isn't real, so it's not really there. So he's scared, and he's got all the physiological responses of a scared mouse, but the thing that is scaring him is not actually there. And so that's kind of the idea behind when you think about anxiety, that there's an overreaction, sometimes learned overreaction to a particular situation or potential event or eventuality that's extreme, that's physiological in nature. So the case that we'll discuss today is a 53-year-old Caucasian male and state employee, Jerry, who presents to treatment at the request of his wife, who reports he has not been himself in recent weeks. He complains of headaches, difficulty sleeping, stomach upset, and excessive worrying. His wife convinced him to come to treatment because of his restlessness, because his restlessness is causing her to lose sleep. You're in a county outpatient mental health clinic and conduct the assessment. You learned that he was an only child who had obtained his law degree only to please my parents. His real interest, he tells you, was in veterinary science. His parents remained married only for him, he explains, and divorced the same year he turned 21. He describes himself as an overachiever and believes he still has these tendencies. So we'll come back and talk about this case. So what is the etiology, or some of the sources or causes of anxiety? And there definitely are cognitive and psychodynamic features to it. And psychodynamic theory would say that anxiety has to do with a conflict between the id and the ego, that aggressive and impulsive drives may be experienced as unacceptable, resulting in repression, and these repressed drives may break through repression, producing automatic anxiety. Cognitive theory has explained that anxiety is the tendency to overestimate the potential for danger, and patients with anxiety disorder tend to imagine the worst possible scenario and avoid situations they think are dangerous, such as crowds, heights, or social interaction. There's also, in terms of etiology, there's predisposition to anxiety. So there are genetic factors that significantly influence risk for many of the anxiety disorders. There also can be predisposition through environmental factors such as early childhood trauma, which can contribute to later anxiety disorders. And some individuals just appear to be very resilient to stress, while others are more vulnerable to stress, which often precipitates an anxiety disorder. There are neurological mechanisms. Really, it's the amygdala that's been implicated in modulating fear and anxiety. Patients with anxiety disorders often show heightened amygdala response to anxiety cues. The amygdala and other limbic system structures are connected to the prefrontal cortex regions. The major mediators of symptoms of anxiety disorders appear to be norepinephrine, serotonin, dopamine, and gamma amino, I'm not sure how to say it, butyric acid, which is GB, better known as GABA. So we talked about in the last webinar about this idea of attachment theory with Bowlby and disruption. Secure attachments can lead to anxiety, so I'm going to say a little bit more about that. I just mentioned the cognitive behavior theory, that negative thought patterns drive related behavior. I'll say a little bit more, I'll talk a little bit differently about self-preservation theory today too, which at its root is the concept of it not being able to find meaning, purpose through daily goal-directed behavior. The role of attachment, and this is, Bowlby did some studies, and then there were studies afterwards that they noticed that childhood circumstances could often lead to later life agoraphobia, for example. So in family conflict situations, such as when the child's need for autonomy and exploration are inhibited by the parents who use restraints and prohibitions, that this can lead to later on anxiety disorders. Or the parents, I don't know why I capitalize parents, but the parents depict the world to their child outside as dangerous and convince the child that they would not be able to withstand its danger without constant parental protection. And parents also, they found in many different kinds of ways, somehow threatened to leave the child alone if they got in trouble, whether through death or sickness or illness. And again, these three things have each been linked to later life anxiety through research. And again, I've talked about, I bring this up almost every presentation because I think it's very useful. When you think about predisposition as being either through genetics or through childhood trauma, which creates that vulnerability to a mental health disorder. And when there's minimal stressful circumstances, there's a much lower probability of having that mental health disorder. On the other hand, if circumstances are very difficult and excessive, there's a much greater probability when there's that predisposition already in place, whether through genetics or through early trauma. So self-preservation theory is concerned about the social evolution of humans and suggests that human identity is inextricably linked to social belongingness. And I see our third person is here. I don't remember your name. I think it was Jennifer. If you would, please write down what your learning goal is for today. I'm glad that you made it, and I'm sorry, it looks like you had some trouble getting connected, but we really are just getting into the meat of this now. But if you want to put your learning goal down as Mary Kay has, we can make sure that we cover that today. The idea behind self-preservation theory is that through millions and millions of years of evolution, I believe that we learn to interact in our social environment in such a way that we would have belongingness in it. And we did that by finding our unique niche in life and offering it. So for example, my last name is Hunter. I could imagine my distant relative was the guy who could throw the spear, drag the buffalo in to feed the people. And that behavior utilized his strengths, and his passion was to be part of this group. And so he did that so that he could be part of this group for all the reasons you'd expect, because there's strength in numbers, there's choice of mates, there's many hands make light work. So I believe that we naturally evolved to that kind of orientation. And when we did that, there's some fundamental aspects that are going on in that, what I call a self-preservation dynamic. And one of them is that you can see, well, first of all, you're utilizing your strengths, you're bringing them to a group that you're passionate about and being part of, that you can see the benefits that you offer and that you get welcoming and belongingness from that. And it defines, it gives you a sense of meaning and purpose, but also in sense defines your identity. I am the hunter, I am the baker, I am the smith, I am the mother, whatever it happens to be. that really helped define you in your role within that particular social group. But the piece that I haven't talked about yet in prior theories, and I was thinking about this for a while today, because this is a very interesting part of this theory, that after that, what the theory says is the brain kind of turned on in some ways and gave us this higher order of thinking. It connected the left and the right brain through the corpus callosum, giving us self-reflection and self-awareness. And I believe when all of that occurred, the cerebral cortex, the neocortex took off, and we had this higher order theory of thinking, that our mind really took us to different places and made everything much more complex in the world. And that the evolution of our cognitive abilities really became a petri dish for mental health disorders in a way, such as anxiety, depression, and addiction, because now we could have belief systems that would drive feelings and behaviors that could be very inconsistent with self-preservation. In other words, if I get rich, I'll be happy, or if I have power, I'll be happy. You know, and I'm oversimplifying it in a way, but I'm trying to make the point that in fact we can learn to believe things that can be completely ridiculous, and yet they drive our daily behavior. And those things that we learn can be somewhat consistent with being healthy and be in growth. And some of those things that we learn can be unhealthy, like in the Bowlby studies that we just talked about. So this is in self-preservation theory, this is kind of the concept of the ideal situation. In the middle, you have very strong M&P, which is meaning and purpose, because your strengths and your passions and your goal-directed actions are tightly linked in service to not only yourself that benefits you, but also us, in theory, all of us. So in the larger scheme, it's actually good for everybody. And then this, again, is reinforced by visible benefits, which is this big arrow coming around the left, and the positive feedback that you get. This completes that self-preservation orientation in the ideal situation. And this is where I think anxiety comes in, where you have this, this is an example of someone who is, I think we talked about either depressed or narcissistic or an addict, whatever, but their goal-directed actions are all about them. They're not really utilizing their strengths and passions and goal-directed actions. They're not bringing them together. In that sense, there's psychological dissonance. There's a disconnect between who they are and what they have to offer and what they're actually doing. And there's the social dissonance piece of this, and I think this is also a source of anxiety, because what they're doing is in conflict, or is actually doing harm to their social groups of belonging, whether it's their family or friends or their job, and also ultimately the larger society as a whole is being affected by it. And so this is where that thinking process, those schemas, can come into play, where for example, with addiction, it's that denial that it's actually doing any harm, and obviously it is doing harm. And the focus, though, for the individual is very myopic in terms of just getting the next drug or whatever it is, and there is not a consideration for the larger social group and that sense of connection and belongingness and meaning purpose. Just moving on from that, so anxiety disorders differ from fear. Anxiety disorders include disorders that share features of excessive fear and anxiety and related behavioral disturbances. Fear is the emotional response to real or perceived imminent threat, whereas anxiety is anticipation of future threat. Fear is more often associated with surges of autonomic arousal necessary for fight or flight, thoughts of imminent danger, and escape behaviors. Anxiety is more often associated with muscle tension and vigilance in preparation for future danger and cautious or avoidant behavior. Panic attacks are part of anxiety, and sometimes the level of fear or anxiety is reduced by pervasive avoidance behavior. Panic attacks feature prominently within the anxiety disorders as a particular type of fear response. And panic attacks are not limited to actually any one disorder, but they're rather, it could be seen in not only in anxiety disorders, but other disorders as well. So the anxiety disorders differ from one another in the types of objects or situations that induce the fear, anxiety, or avoidance behavior, and the associated cognitive ideations. Although they tend to be highly comorbid with each other, they can be differentiated by close examination of the types of situations that are feared or avoided and the content of the associated thoughts or beliefs. but they certainly can be comorbid anxiety disorders. Anxiety disorders differ from developmentally normative fear or anxiety by being excessive or persistent beyond developmentally appropriate periods. And they differ from transient fear or anxiety, often stress-induced, by being persistent, typically lasting 6 months or more. And since individuals with anxiety disorders typically overestimate the danger in situations they fear or avoid, the primary determination of whether the fear or anxiety is excessive or out of proportion is made by the clinician in consideration of cultural factors as well. Many of the anxiety disorders develop in childhood and tend to persist if not treated. Most occur more frequently in females than males in approximately 2-to-1 ratio. And each anxiety disorder is diagnosed only when the symptoms are not attributable to the physiological effect of a substance or medication, or attributable to another medical condition, or not better explained by another mental health disorder. So the first one we're going to talk about is separation anxiety. Individuals with this disorder are fearful or anxious about separation from an attachment figure to a degree that is developmentally inappropriate. Obviously, this is with children. There's a persistent fear or anxiety about harm coming to attachment figures and events that could lead to the loss of separation from attachment figures and reluctance to go away from attachment figures, as well as nightmares and physical symptoms of distress. Although the symptoms often develop in childhood, they can be expressed throughout adulthood as well. So the diagnostic criteria for separation anxiety disorder are as follows. There's developmentally inappropriate and excessive fear or anxiety concerning separation from those to whom the individual is attached, as evidenced by at least 3 of the following, and this goes on to the next page. So recurrent excessive distress when anticipating or experiencing separation from home or other major attachment figures. Persistent and excessive worry about losing major attachment figures or about possible harm to them, such as illness, injury, disaster, or death. Persistent and excessive worry about experiencing an untoward event, such as getting lost, being kidnapped, or having an accident or becoming ill, that causes separation from a major attachment figure. Persistent reluctance or refusal to go out, away from home, to school, to work, or elsewhere because of fear of separation. And again, this is continuing on. Persistent and excessive fear of or reluctance about being alone or without major attachment figures at home or in other settings. Persistent reluctance or refusal to sleep away from home or to go to sleep without being near a major attachment figure. Repeated nightmares involving the theme of separation, or repeated complaints of physical symptoms such as headaches, stomach aches, nausea, and vomiting when separation from major attachment figures occurs or is anticipated. The fear, anxiety, or avoidance is persistent, lasting at least 4 weeks in children and adolescents, and typically 6 months or more for adults. And the disturbance causes clinically significant distress or impairment in social, academic, occupational, other important areas of functioning. So again, it's going to be at least three of any of the following of those. Selective mutism is now under anxiety disorders in the DSM-5. And this is characterized by a consistent failure to speak in social situations in which there is an expectation to speak. For example, in school, again, this is in childhood, even though the individual speaks in other situations. The failure to speak has significant consequences on achievement in academic or occupational settings, or otherwise interferes with normal social communication. And again, the diagnostic criteria are the following: consistent failure to speak in specific social situations in which there's an expectation for speaking, such as school, despite speaking in other situations. The disturbance interferes with educational, occupational achievement, or with social communication. The duration of the disturbance is at least 1 month, not limited to the first month of school. And the failure to speak is not attributable to a lack of knowledge of or comfort with the spoken language required in the social situation. And the disturbance is not better understood by communication disorder, such as childhood onset fluency disorder, and does not occur exclusively during the course of autism spectrum disorder, schizophrenia, or any other psychotic disorder. Phobias are also part of the anxiety disorders. And probably we're most familiar with the phobias and the diagnoses, but basically it's the fearful or anxious about or avoidant of circumscribed objects, or situations. A specific cognitive ideation is not featured in this disorder, as is in the other anxiety disorders. The fear, anxiety, or avoidance is almost always immediately induced by the phobic situation to a degree that is persistent and out of proportion to the actual risk posed. There are various types of specific phobias, and they could be to animals, to natural environments, to closed spaces, to blood injection, to injury, blood injection injury, to situational and other situations. So in terms of the diagnosis, it's a marked fear or anxiety about a specific object or situation. In children, the fear or anxiety may be expressed by crying, tantrums, freezing, or clinging. The phobic object or situation almost always provokes immediate fear or anxiety, and the phobic object or situation is actively avoided or endured with intense fear or anxiety. The fear or anxiety is out of proportion to the actual danger posed by the specific object or situation and to the sociocultural context. The fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more. The fear, anxiety, or avoidance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, and the disturbance is not better explained by the symptoms of another mental health disorder. So moving right along, the next is social anxiety disorder. This is fearful or anxious about or avoidant of social interactions and situations that involve the possibility of being scrutinized. These include social interactions such as meeting unfamiliar people, situations in which the individual may be observed eating or drinking, and situations in which the individual performs in front of others. The cognitive ideation is of being negatively evaluated by others, being embarrassed, humiliated, or rejected, or offending others. There's a marked fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. Examples would include social interactions, having a conversation, meeting unfamiliar people, then being observed, such as eating or drinking, and performing in front of others, such as giving a speech. In children, the anxiety must occur in pure settings and does not just during interactions with adults. And the individual fears that he or she will act in a way or show anxiety symptoms that will be negatively evaluated, will be humiliating or embarrassing, or will lead to rejection or offend others. The social situations are avoided or endured with intense fear or anxiety. The fear or anxiety is out of proportion to the actual threat posed by the social situation in the social cultural context. The fear, anxiety, or avoidance is persistent and typically lasting 6 months or more. The fear or anxiety or avoidance causes clinically significant distress or impairment in the social, occupational, other important areas of functioning, as with the other ones. Significant distress or impairment in social, occupational, other important areas of functioning. The fear and anxiety avoidance is not attributable to physiological effects of substance abuse, such as alcohol or some other drug of abuse, or a medical condition. And the fear, anxiety, or avoidance is not better explained by the symptoms of another mental health disorder, such as panic disorder, body dysmorphic disorder, or autism spectrum disorders. And if another medical condition, such as Parkinson's, obesity, disfigurement for burns or injury is present, the fear, anxiety, or avoidance is clearly unrelated to or is in excess of what would be expected. Okay, the next one is panic disorder. This is when the individual experiences recurrent unexpected panic attacks and is persistently concerned or worried about having more panic attacks, or changes his or her behavior in maladaptive ways because of the panic attacks. For example, avoids exercise or unfamiliar locations. Panic attacks are abrupt surges of intense fear or intense discomfort that reach a peak within minutes, accompanied by physical and or cognitive symptoms. Limited symptom panic attacks include fewer than 4 symptoms. Panic attacks may be expected, such as in a response to a typically feared object or situation, or they can also be unexpected, meaning that the panic attack occurs for no apparent reason. They function as a marker and prognostic factor for severity of diagnosis, course, and comorbidity across an array of disorders, including but not limited to anxiety disorders, so also including substance use, depressive, and psychotic disorders. Panic attack may therefore be used as a descriptive specifier for any of the anxiety disorders as well as other mental disorders. So, but in terms of the panic disorder diagnosis, it's a recurrent unexpected, there are recurrent unexpected panic attacks. And a panic attack is an abrupt surge of intense fear or intense discomfort that reaches peak within minutes and duration, which time four or the more of the following symptoms occur. Okay, so these are the symptoms that occur during a panic attack. There's an abrupt surge. Oh, I'm sorry. An abrupt surge can occur from a calm state or an anxious state. So those symptoms, any four of the following: palpitations, pounding heart or accelerated heart rate is one; sweating, trembling or shaking, sensations of shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heat sensations, paresthesias, I don't even know how to say that, numbness or tingling sensations, derealization, which is a feeling of unreality, or depersonalization, being detached from oneself, and fear of losing control or going crazy, and fear of dying. So those, it's going to be at least four or more. There can be cultural specific symptoms that are seen. Such symptoms should not count as one of the four required symptoms. At least one of the attacks has been followed by 1 month or more of one or both of the following: persistent concern or worry about additional panic attacks or their consequences, such as losing control, having a heart attack, or going crazy, and or a significant maladaptive change in behavior related to the attacks. For example, behaviors designed to avoid having panic attacks, such as avoidance of exercise or unfamiliar situations. And the disturbance is not attributable to the physiological effects of substance, such as drugs of abuse or medication or any other medical conditions, such as hyperthyroidism, cardiopulmonary disorders, etc. And the disturbance is not better explained by another mental health disorder. Okay, the next one under the anxiety disorders is agoraphobia. And there's a fearful, with this, the person is fearful and anxious about two or more of the following situations: either using public transportation or being in open spaces. Two or more of the following: using public transportation, being in open spaces, being enclosed in enclosed spaces, standing in line or being in a crowd, or being outside of the home alone in other situations. The individual fears these situations because of thoughts that escape might be difficult to help. The individual fears these situations because of thoughts that escape might be difficult or help might not be available in the event of developing a panic-like symptoms or other incapacitating or embarrassing symptoms. These situations almost always induce fear or anxiety and are often avoided or require the presence of a companion. So if, in terms of the diagnostic criteria, there's a marked fear or anxiety about two or more of the following five situations: using public transportation, being in open spaces, being in closed spaces, standing in line or being in a crowd, or being outside of the home alone. The individual fears or avoids these situations because of thoughts that escape might be difficult or help might not be available in the event of developing the panic-like symptoms or other incapacitating or embarrassing symptoms. I just wanted to take a minute and explain to Mary Kay, you know this, but our other viewer, I think her name is Jennifer, that there is about a 10-second delay. So I apologize if the slides are not lining up perfectly. But one of the reasons why I put as much information as I do on the slides, if there's any sound problem or any issue, hopefully you can still follow along. Actually, it looks like she's gone, so that's too bad. Okay. So with agoraphobia, the situations almost always provoke fear or anxiety. The agoraphobic situations are actively avoided, require the presence of a companion, or are endured with intense fear or anxiety. The fear or anxiety is out of proportion to the actual danger posed by the agoraphobic situations and to the sociocultural context. The fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more. The fear, anxiety, or avoidance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. And if another medical condition exists, such as inflammatory bowel disease or Parkinson's disease, the fear, anxiety, or avoidance is clearly in excess of what you would expect for that condition. And the fear, anxiety, or avoidance is not better explained by the symptoms of another medical disorder. Okay, so the last one we're going to talk about is generalized anxiety disorder, or GAD, and our case is going to be specific to this as well. So there's a persistent and excessive anxiety and worry about various domains in one's life, including work and school performance, that the individual finds difficult to control. In addition, the individual experiences physical symptoms, including restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, and sleep disturbance. So the criteria for GAD, or generalized anxiety disorder, are as follows. Excessive anxiety and worry, which is apprehensive expectation, occurring more days than not for at least 6 months, about a number of events or activities such as work or school performance. The individual finds it difficult to control the worry. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms having been present for more days than not for the past 6 months. Okay, so by the way, only one item is required for children. So those 6 are restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, or sleep disturbance, difficulty falling or staying asleep, or restlessness or unsatisfying sleep. Again, there's excessive anxiety and worry. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The disturbance is not attributable to the physiological effects of the substance or another medical condition, and the disturbance is not better explained by a mental health disorder. And just very quickly, it's important to rule in or out other causes of potential potential disorders that look like anxiety disorders. And again, those are substance or medication-induced anxiety disorder. In this case, it involves anxiety due to substance intoxication or withdrawal, or to a medication treatment, or an anxiety due to other medical conditions. Anxiety symptoms are the physiological consequence of another medical condition. Okay, so again, we have this concept of this anticipated fear of something that isn't really there, and there's a whole physiological response that's going on. All right, so we're going to go back to this case that I introduced earlier and continue on. This is Stephen. He has been working for 24 years in the same state law position and reports he finds lawyering deeply dissatisfying. He states the only reason he leaves the house in the morning is to get away from his wife, Jessica, the nag, who always complains about his lack of promotion at work and lack of money. I hate my line of work, he says. With regard to his wife's family, he reports she has always been insecure because her father, a drunk, left her and her sisters and mothers when she was 14 years old as an oldest child. Her mother found work in retail industry which left Jessica, his wife, to raise her younger siblings, then 4 and 7 years old. She married me for financial security reasons. I get that, he says. They have one child, age 26, who's followed in her father's footsteps, much to his chagrin. He would have preferred she pursue a degree in pharmacy or medicine, but she was interested in getting her degree as quickly as possible to make money and live large, as she said, live large in New York City. She had compromised by specializing in medical malpractice. She is recently married and lives in New York City, the opposite side of the country as her parents, who are in Southern California. With regard to the marriage, Jerry is mostly dissatisfied. In addition to her constant nagging, he remarks their sexual encounters happen once in a blue moon. When asked to be more specific, he states, I can't remember the last time, if that helps. He replies their best times are spent reading books together. He can't remember the last vacation he enjoyed with her, instead only those when his daughter had come years ago. They've been married for 33 years. Financially, he says, we struggle at times because we live way above our means. He says he earns $120,000 per year, but we live in a $500,000 home with $500,000 worth of accessories, and that doesn't include Jessica's wardrobe. Regarding his leisure time activities, he reports he enjoys bike riding. He gives me a sense of freedom and control. He reports that at times he has seriously considered riding on and never turning back, never to return. In recent weeks, though, his desire to ride his bike has decreased, as has his actual riding, which had been daily and is now once per week, and from 30 miles to 3 miles per day. I've lost my passion for it, I guess, he remarks in deep contemplation. He worries about his daughter's well-being and attempts to reach her at many different times of the day, losing sleep if he does not reach her by evening. He worries about his finances, checking the balance of their accounts, checking on investments, and running bankruptcy scenarios in his head daily. He has called a bankruptcy attorney weekly in recent months to discuss their options should they fall short of paying the bills, which has not happened yet, and his credit score is over 800. He is also concerned about his marriage, realizing that he married the wrong woman and constantly thinks about where he may have gone wrong. He has experienced excessive restlessness and subjective distress due to this constant worry, which has affected his relationship with his daughter and wife, and his coworkers have questioned what they perceive as his distractedness and nervousness on the job. So this is Stephen. So I'm assuming it's you, Mary Kay, who's still on, and we lost somebody, the other viewer, unfortunately, I think. So what are 5 diagnostic criteria and or prominent symptoms exhibited by this case example? And I'll go back to at least the last slide. So I did say it was generalized anxiety disorder, but what are 5 symptoms that you would point to that would say clearly this is generalized anxiety disorder? I'll give you a couple minutes to do that one. Okay, I'm going to, I'm looking at your question and thinking about it as well, or your learning goal, what you want to talk about. All right, so you've identified 5 diagnostic criteria and or prominent symptoms. Just briefly, I'll talk about some tools, the patient status update report, which we have talked about already, which is basically what of those areas have been of increased stress, focus, or concern since the last time we met. Again, this can be extremely helpful to kind of get a handle on what's going on for your patient and how bad it is, how bad certain circumstances are to them from their perspective. It can be extremely helpful in getting a handle on anxiety level as well, because if they're pointing to 7 or 8 or 9 areas that are of extreme stress, focus, or concern, you can be sure their anxiety level is high, and then you can start exploring, each of those to kind of figure out what the source is of those situations. There is the Beck Anxiety Inventory, which is a 21-item scale that has been used and it's been shown to be very helpful. There's a shorter tool that's used specifically for anxiety called GAD-7. And by the way, these are, I would have put the web links on here, but they're actually quite easy to locate. So you can go ahead and Google these if you want to take a closer look. And another one that's very helpful is the Hamilton Anxiety Scale, which is a 14-item scale. So each of these are tools that can be very helpful in looking at someone with anxiety disorder. And you might actually, with your 80-year-old patient, consider using this for that patient, Mary Kay. So what do you think are some of the potential, describe the potential impact and benefits of the presented assessment tools and strategies as part of your biopsychosocial spiritual assessment process? So again, this is question 2 on the worksheet. What is the potential impact and benefits of those tools in your assessment process? I'm going to give you a minute or 2 for that one. Okay, and then we have the dialogue. So John, I should have said Steve, but we'll go with John. I'm at the end of my very, very thin rope, he says to you. And you say to him, your willingness to come to see me today tells me a lot about your fortitude and resilience. Okay, but now what, John says. And you say back to him, I'd like to ask you some more questions about your recent changes in behavior. So based on what you remember of John's story, and I'll go back up again to one of the earlier slides, what are some additional questions that you would have diagnostically or in the way of starting to formulate what your treatment plan would look like? So again, I'll go back up to, it's hard to remember this. You probably got a lot of that, so let me see. I'll leave it on this slide for a minute, and then I'll move up to the one above this. So what are some additional questions that you would have that would help you either formulate your diagnosis or begin to develop treatment goals? Okay, I'm going to go up one slide. Okay, and there's a couple more slides as well. I'm sure you're probably done. Let's give me another minute. Okay. Okay, so we're at the end, but I wanted to address your learning goal. So when I think about an 80-year-old patient, Mary Kay, I assume that's you still on. Just thinking about your learning goal, I think that there is so much to be scared about. Losing control. I mean, the medical issues, a threat to his life, and I think not knowing anything else about the history of this person, trying to get an understanding of his beliefs about the afterlife and where he goes from here. So, one of the things I wonder is, was he always this anxious and fearful? It sounds like it was in response to the recent medical issue, but I'm not completely sure. But, starting to explore, is there an afterlife? And, does he have those kinds of beliefs? Has he done what he wanted to do in his life? Has he done good? To focus on the positives and and the transitional elements of what he leaves behind, what his legacy is. Not that he's necessarily dying yet, but as a way of easing him into this idea that he's he may be gone, but what he's done and created is still going to be there and will live on. And so those are the kinds of conversations that I think can help someone, because I'm assuming that this is an end of life concern that he has and fear of dying. I'm not 100% sure, but I'm guessing that's what you're talking about. There's no social support. He's separated from his wife. He's just trying to die. And is he he's in a nursing home? I think you said that's the level of care you're working at. Yeah. So I think that and usually when you think about those regrets, or if you help him just talk about those regrets, and then because that's kind of the if you think of it from a cognitive behavioral perspective, that those are all the things that I did that were bad, that I screwed up, and I and then you're looking at from a cognitive perspective, using Socratic questioning. So what evidence is there that you really did screw up your kids, or that if this happened or that happened? And then is he taking a balanced perspective of the kinds of things that happened in his life? In terms of the things, what he faced with under the circumstances. You were faced with this, or you're faced with that, and you did your best. So again, pulling out the strengths he had and that he brought to bear, and pointing out that some people couldn't have managed better than he did under certain circumstances, if that's the case. And again, I don't know enough about your case to really say. But I think that a lot of older people deal with, you know, those kinds of things by, you know, praying over it, by visiting with a pastor or a priest or whoever who can talk to him about it and help him come to a place where he's forgiving and more understanding of himself, you know, forgives himself and is more understanding of, you know, the way things were and the way things are going, and where he'll come to his rest. So that's another angle at that, the spiritual angle, that I would suggest that you might want to consider if he hasn't done that already. Okay, so we are at least 50 minutes in. Did you want to say anything else about that, Mary Kay? Yeah, I would definitely say that's a great angle to go with. That can be very, very helpful in helping someone feel more at ease, but also the piece where he takes a more balanced perspective of what he's done and hasn't done, and the circumstances under which those things happened, and then focus on the positive things that he did leave behind as well, and the contributions that he made despite difficult circumstances, because everybody has their own set of difficult circumstances that they you know, learn to work through, or try to work through, or survive through the best they can. So I think that combination should be very helpful. Well, thanks for coming, Mary Kay. He was raised Jewish and is now going to a Christian church. Yeah, you know, and they do differ, but I think there's overlap too. Yeah, definitely worth exploring, and you know, helping him sort through all that, I think, will put his mind at ease and bring him to a better place. It's interesting. Okay, next week is going to be on anxiety again. We'll talk about treatments, and hopefully you'll be able to come. And you know, we almost had another person today. I know there are a few people who are saying they're going to be coming soon, so I'm hoping that we'll keep growing the webinar series, but I'm going to be here regardless. And I appreciate you coming again, Mary Kay. So have a great week, and hopefully I'll see you next week. Thank you. Thanks for coming. You too. Thank you.